and a very warm welcome to everyone. My name is Victoria Beadle, and I'm the CEO of Melanoma Patients Australia and your host for this evening's consumer webinar, which will shine a light on the very important issue of rare and difficult diagnosis of mucosal melanoma. First of all, I would like to acknowledge our country. We pay respects to the traditional custodians of the lands and their elders, both past, present and emerging, and acknowledge the deep continuing connection of Aboriginal and Torres Strait Islander peoples to the land, waters and sky. In tonight's webinar, it's part of a series. We already completed webinar number 1 last week, which was a spotlight on clinical trials. And that recording is now available. If you missed that, you're very welcome to look for that on both the MIA and MPA websites. This evening, we're doing our spotlight on mucosal melanoma, and next Wednesday, we will be placing a spotlight on fear of recurrence. We'd love you to join us. There is a QR code on the screen here that you can scan to register, or you can drop onto the MPA or MIA websites and register for the forthcoming event on Wednesday, the 9th of August. Okay, we'll get started with the main event for this evening, our spotlight on mucosal melanoma, and I'd like to introduce our speakers to you. Our first speaker of the evening will be Associate Professor Matt Carlino, followed by Judy Maloney, who'll be sharing her personal story. Associate Professor Matt Carlino is a medical oncologist at Melanoma Institute Australia, Westmead and Blacktown Hospitals, and is an associate professor at the University of Sydney. He's an investigator on many clinical trials on targeted immunotherapy treatments in melanoma and has a research interest in mechanisms of resistance and lots of experience in the area of mucosal melanoma. Welcome, Associate Professor Carlino.
Thanks, Victoria. So as Victoria introduced, my brief today was to talk you through some of the data on mucosal melanoma. And really the way I frame this presentation is in some ways a comparison to cutaneous melanoma, because we often see data presented, and even as oncologists, we need to tease out what data applies to what patients, no matter really what subtype of melanoma they've got. As Victoria mentioned, I'm a medical oncologist, so I will touch on surgery, but certainly I'm not a surgeon. I'll talk you through some data, but also some practical measures. So the things I'm going to go through are epidemiology and genetics. What is the difference between cutaneous melanoma and mucosal? Surgery, as I said, the caveat being I'm not a surgeon. Drug therapy, both for mucosal melanoma that's spread to other parts of the body, but also mucosal melanoma drug therapy after surgery, which is a topic, quite a complex discussion. And finally, some future directions. So I put up this slide. This is a slide I borrowed from a Chinese colleague of mine, Dr. Lu Si, when I was at a talk in Beijing. And the figure in green is the percentage of patients in a US population that have subtypes of melanoma. And SSM is superficial spreading melanoma, the most common type of skin melanoma we see. Mucosal melanoma doesn't even get its own box here. It's within the other box. And really it's less than 1% of this population. And that is why often it's hard to get data on mucosal melanoma, at least in a Western country. If you compare this to some Chinese data, the mucosal population in this MCM acronym is over 20%. So a lot of our data on mucosal melanoma really comes from this excellent group in China from Peking University in Beijing. So what causes melanoma? So I think if you asked anyone what causes cutaneous melanoma, I think most people would say the main factor is the sun and UV damage. And we know that when we look at cutaneous melanomas, there is some very obvious DNA damage that is the cause of the melanoma. And so these certain types of DNA damage we get from UV light, and you can actually see these if you look at the melanomas. It's a bit like the signature we see from smoking in a smoking-related cancer. And if you ask me or you asked anyone what causes mucosal melanoma, and the honest answer is we don't know. So that's our first difference and our first trouble, because if you don't know what causes it, how do you reduce the risk of it and how do you prevent it? So genetics, there's been a number of studies, and the first question is mucosal melanoma genetically different? And the short answer is yes. There are less point mutations. So what a point mutation is if you look at our DNA, all of our DNA, there are single point errors in that genetic code. And melanoma, skin melanoma, has many errors. So if you look at this graph, these are melanoma samples from multiple patients from MIA. The grey ones are people with skin melanoma. The black ones are people with what's called acral melanoma, which I'm not going to touch on tonight. It's melanoma from the soles of the hands and feet. And mucosal is the white group. And the number of mutations, so the number of DNA errors, are substantially lower. If you look over here in the black and the black and the white groups, the mucosal and the acral groups, than they are in skin. And this is important because this does impact treatment, which I'll touch on later. The other thing to say is even when you look at these mutations, they're different. What this group did, led by Nick Haywood, a scientist out of Brisbane, is they looked at the type of genetic mutations. And the summary is these violet mutations across here actually are due to UV damage. So we know mucosal melanoma isn't caused by the sun. We see some UV damage, particularly for melanomas that may come from the lip or in the inner mouth, because perhaps you're obviously more likely to get sun exposure there, but nowhere near the amount of sun damage than you do. But we get another type of DNA change. This is what we call a structural change. So we all have these things called chromosomes in our body. And a structural change is where a bit of the chromosome gets copied. So this is on the top, we copy a chromosome. Or a bit of the chromosome gets deleted. Or a bit of the chromosome swaps. This is a swap between one chromosome and another. And these structural changes are more common in mucosal melanoma. And this is the data to show that. And once again, this may, in the future or even at present, give us some treatment hints. Whenever I see a melanoma patient, we do some pretty basic genetic testing where we look for a bunch of relatively common mutations. And these mutations are important because they're druggable. And so the most common one of these is a mutation called BRAF. People may have heard of BRAF mutations in melanoma. And in skin melanoma, about 40% of our patients will have a BRAF mutation. That number is lower in mucosal melanoma. And further, the type of BRAF mutation is different. So there's a type of BRAF mutation which has a tablet drug really made for those melanomas. And while you do see those mutations in mucosal melanoma, it's substantially less common. So we look for those mutations, but they're less common. There's another type of mutation, it's called a thing called a KIT mutation, which is the other way. It's rarely seen in skin melanoma, but up to about 15%, perhaps more patients with mucosal melanoma will have that. And once again, I'll talk to you about why these mutations matter when we get to the treatment part. So the next thing, and this is not data, but this is my experience, is how's a diagnosis made? When I see someone with skin melanoma, a very common story is they saw their GP, or they saw their skin cancer clinic, or their spouse noted a mole on their back or their arm that was changing, and they somehow got to a skin doctor or a dermatologist, and they often get a biopsy. And this is a picture of what's called a punch biopsy. And really, any doctor can do a punch biopsy. It's quite simple. It's quite easy. In patients with mucosal melanoma, this is a picture of someone who's got a melanoma inside their mouth. The diagnosis is not always obvious. The most common way I hear about a patient who's had a mucosal melanoma is almost an unexpected melanoma. I'll get a phone call from a gynecologist or a colorectal surgeon saying, I removed this, not sure what it was, and the pathology came back melanoma. Very unexpected. So that's quite a difference in how patients get to me and how they get their diagnosis. The second thing that's different is the teams that we have set up to take care of people. So if you went to the Melanoma Institute or Westmead Hospital or any major teaching hospital, there would be a melanoma multidisciplinary team. And among other people, there'd be dermatologists and there'd be melanoma surgeons and there'd be someone like me there. And of course, we also have pathologists and radiologists. In mucosal melanoma, the diagnosis is not typically made by a melanoma doctor, and it's typically not made by a non-melanoma doctor. And so these teams are different. So at Westmead, how the model works is it's a little bit individualized. So the most common way I hear about a mucosal melanoma, and this happened today, is one of the gynecologists, as an example, will call me. So we have a big department of gynecology oncologists at Westmead, and I'll get a phone call saying, Matt, we saw a lady today and we've biopsied a melanoma. What we often then do is I'll attend their MDT, or I'll meet that patient and take the patient to the melanoma MDT. I don't go to every gynecology MDT because 9 out of 10 meetings won't have a melanoma patient. But you need this very individualized approach to patients. And I do the same if someone had a head and neck, a nose melanoma as an example, or another part of the body. This is perhaps a controversial comment, but I think ideally, if a patient has a mucosal melanoma, I think there is a benefit of at least having the input from a melanoma medical oncologist. So there are some fantastic medical oncologists around the country who treat multiple different cancers. But it's nice to have the input of someone who spends most of their time thinking about melanoma. And that doesn't necessarily mean you are disadvantaged if you don't live next to the Melanoma Institute or you don't live next to Peter MacCallum in Melbourne, because we often have inputs into patients' care, even patients we've never met. So I've got some excellent colleagues who work in rural New South Wales, at Orange and Wagga, for example, and they'll often dial into our MDT, and that way you get the benefit of getting treatment and seeing a doctor close to home, but if you like, you get the opinion of a wider melanoma group. So surgery. So most mucosal sites are harder to operate on. So that picture of the round circle on the thing, imagine if that was my back or my arm, and a surgeon decided to remove a mole on my arm or a melanoma on my arm with 2 centimeters around it. They would do a large cut and they would stitch that cut together, and I'd have a scar, and that scar might end up being 10 centimeters long. But it's relatively easy for that surgeon to remove a melanoma on my arm or my back or my chest with a large margin. Clearly, if that lesion is in your mouth or somewhere else where it's hard to operate, it's much harder to get close margins. So our surgical colleagues often have discussions about what margins they would like surgically, or what margins can they get. The second thing is finding the draining lymph node. We often remove the draining lymph node from a melanoma. That gives us some guidance about prognosis and may guide treatment. This is a picture of a melanoma on a man's arm, and the typical lymph node is under the arm. Very easy to get to. The lymph nodes in some mucosal melanomas may be easy to get to. So as an example, you could have a melanoma in a gynecological area and the lymph node may be in the groin. But also sometimes those lymph nodes can be deep within your abdomen or your pelvis, which is obviously harder to get to. So moving on to drug therapy, I'm going to talk about targeted therapy and immunotherapy. So the first thing is I talked about those BRAF mutations. BRAF inhibitors, tablet treatment for BRAF inhibitors, are very active in BRAF mutant melanoma. Patients with mucosal melanoma could have gone on our clinical trials where we tested these drugs, but they were a very small minority, and we actually don't have that data. I cannot get a clinical trial and pull out that data for you. So we turn to big case series from Asia, and a number of Chinese and Japanese doctors have looked at a huge number of patients. And even in Asia, where mucosal melanoma is more common, in a case series of 112 patients, there was only 3 patients with mucosal melanoma. We can extrapolate, and we know what I've done with these figures. This is looking at acral melanoma, which is very genetically similar to mucosal. We know that in these Asian populations, an acral melanoma, and this included the 3 mucosals, the chance of the drug working was 80%. And that chance of the drug working, shrinking the melanoma, is the same as if that patient had a skin melanoma. So the summary, when I'm thinking about a BRAF mutant mucosal melanoma, I think targeted therapy works just as well, irrespective of where that melanoma came from. The key to these drugs working is that the BRAF mutation is there. The next thing I mentioned was these things called KIT mutations, which are more common in mucosal melanoma. There is a tablet drug that works in KIT mutations. It doesn't work in all of them. And so oncologists know, or if they can look up which mutations they work well in and which ones they don't work well in. This drug is actually not made for melanoma. It was made for a rare type of sarcoma of the stomach, but then we worked out it does work for melanoma. And so when they looked at every patient, a large number of patients with KIT mutant melanoma, about 15% had a shrinkage of their tumour. But when they looked at the group where it actually should work, you know, the ones that we predicted it would work, that number's higher. And similarly, in mucosal melanoma, my reading of this study is that the chance of shrinkage doesn't matter if the melanoma started on the skin or a mucosal area. The important thing is, does that melanoma have the right type of mutation? And certainly I've had patients with mucosal melanoma and a KIT mutation respond to these drugs. This drug, unfortunately, is not funded in Australia for melanoma, but I've used it and I've had a number of patients where it's helped them by shrinking their melanoma. When people think about drug treatment for melanoma, they think about the immune therapy most commonly, and people would have perhaps heard of drugs called nivolumab and pembrolizumab and ipilimumab. This is a really well-known figure in melanoma. What these are curves, and this was 1,000 patients who went on a clinical trial of nivolumab or ipilimumab, or the two together. And in some ways, these curves are quite sad, because as this curve goes down, it means these are people who have died of their melanoma. But what this curve tells us is there's approximately 50% of people with who are alive many years after starting, 6-7 years after starting treatment. This trial allowed patients with mucosal melanoma in it, but the vast majority of people on these curves are skin melanoma. So it's very hard to say, does this data apply to mucosal melanoma? So what was then done is the data from a couple of different trials of patients getting nivolumab and also nivolumab plus ipilimumab. They teased out the patients who had skin melanoma and the patients who had mucosal. And you can see, first of all, there's a lot more skin patients. So if we look at the patients getting nivolumab alone, 86 mucosal patients, 600 odd cutaneous skin. And what they found is the response rate, so ORR stands for overall response rate, was lower in the mucosal patients. So the chance of nivolumab shrinking your melanoma was lower if you had mucosal melanoma than if you had skin melanoma. And we think one of the drivers of this being lower was that amount of mutations I talked about earlier. Any cancer that has a higher number of mutations is more likely to respond to immune therapy. Similarly, when we looked at the people getting combination immunotherapy, so this is perhaps felt to be our most active drugs, the chance of response, the chance of shrinking was lower if you were getting the combination. Now, it's a little bit controversial, this data, because other studies have looked at the same question. Should patients get one drug, nivolumab or pembrolizumab, or the combination of ipi-nivo? Remembering that ipi-nivo has higher levels of side effects. So this is why we really struggle with this question. So there was a large study led out of MIA by one of our fellows and led by Georgina Long, where we looked at over 500 mucosal patients from around the world. Some got immunotherapy with one drug, some got 2 drugs. And interestingly, we found the numbers were quite similar. The chance of shrinkage was very similar. Now, this is not a clinical trial. This is what we call a retrospective study, but still, this does inform us that in my mind, we need to improve what we're doing. This is not good enough. We would prefer a number where this blue circle was 100%, or ideally we'd want that number to be at least as high as skin melanoma. The new kid on the block, the new drug for melanoma, is what we call relatlimab. And this will very soon be available in Australia and is available now pretty easily to get hold of at big melanoma centres like Westmead and MIA. The study of this drug combination had 7% of papers with mucosal melanoma. So at least we looked at the patients differently. We're learning. We're now teasing out this group of patients. This is another way to present data. So we've got response rate, and this little blue dot was the response rate for these patients. 25% of people got shrinkage. But there wasn't a lot of difference. That dotted line essentially showed if the two drugs together was better than one drug alone. And it wasn't that convincing that two drugs was better than one. So the question of two drugs versus one drug in mucosal melanoma is a complex discussion that needs to be individualized. So adjuvant therapy. Adjuvant therapy is drug therapy after surgery. We know that people who have had a melanoma removed have a risk of recurrence. And the standard approach for skin melanoma is to give people often pembrolizumab or nivolumab, those immune therapies. And we ran large clinical trials of these drugs with thousands of patients. The pembrolizumab trial didn't allow patients with mucosal melanoma, not at all. The nivolumab trial only had a few patients, so you cannot use this trial data to decide. So what do we look at? We look at case series, retrospective data, like I just showed you, and there is data from China. So last year, one of my fellows, Sarah Jacques, who was working for me, did a very similar study. She went around to all the big melanoma centres in the world and said, find me all your patients who've had drug treatment for those two rarer subtypes of melanoma after surgery. And we had 55 patients with mucosal melanoma who'd got drug treatment after surgery. And then we compared them to people in our database. So people who come to Westmead and MIA get consented to a database. And that database gave us information from people who had mucosal melanoma before these drugs existed. And we found that when we compared those people with the drug and those without, that their outcome, the chance of their melanoma coming back, looked very similar. So there was no good evidence that the drug was reducing the risk of the melanoma coming back. We then turned to the Chinese data. So this was data presented this year in June, where our Chinese colleagues looked at patients getting chemotherapy and also their patients getting immune therapy. This is the Chinese version of Pembro or Nivo. And they found that the patients who got chemo surprisingly had a lower, their cancer came back later than the ones getting immune therapy. The question is, does this data from China, from one hospital in China, so we've got to be a little bit cautious, apply to all around the world and different patients? So there are a number of things that I think make our progress difficult. Mucosal patients are often excluded from trials. So this is a cut and paste from a clinical trial that's opening really this week all around Australia. And unfortunately, under section 5.2, it says patients are excluded if, unfortunately, they have eye melanoma or mucosal melanoma. So it's a bit disappointing that we can't answer that question. Even when they're not excluded, you don't have enough mucosal patients to tease out, did the drug help them? Because that's the question. We want to work out the best treatment for different people. The best data comes from China, and the Chinese group are fantastic. But the question is, does that data apply to our patients? So one thing that has shown promise is this idea of targeting a thing called VEGF. VEGF is called vascular endothelial growth factor. It affects the tumour blood supply. And a lot of the drugs that we use that target VEGF are commonly used in kidney cancer. Multiple studies, mainly from China, have looked at these drugs. So this is data from one of them. It's got immunotherapy, that's the torelumumab, and axitinib is a drug they use in kidney cancer. And each of these lines is a patient, and a line going down means there was shrinking of the tumour. So here in a mucosal population, we're seeing almost 50% of patients getting a significant shrinkage. So really suggesting perhaps this is a strategy we should be employing for our mucosal patients. Other future directions. I touched on earlier these DNA rearrangements that we see in mucosal melanoma. They're not found with the standard genetic testing. So the standard genetic testing we do for every patient doesn't pick up these rare rearrangements. They can be found with more detailed testing. So one of the things we're doing with MIA is we take every patient who comes in the door with advanced melanoma. If they've got one of those common mutations, we don't do any further testing because you don't usually have two. But if those patients don't have a common mutation, we do some quite detailed testing to look for these rarer things, hoping to find a drug. And some of these rarer things are druggable. So without going into detail, this is one of these patients who has one of these rarer druggable mutations. And what we did, what the scientists who did this study did, is they actually took a drug from lung cancer and gave it to a melanoma patient and had a substantial shrinkage in the tumor. These things are very rare, so you've got to look because there's lots of different potentially druggable things, and you don't know which patient has which one. So future directions. I think we need either dedicated trials just for mucosal patients, right? And we could run them around the world quite easily. Or we get a big melanoma trial that's for all melanoma patients, but we have a separate cohort just for mucosal. So whenever we get the data, we can say, right, there was 1,000 patients with skin melanoma, and this is what happened. But in the 100 patients with mucosal melanoma, this is what happened, but a separate group. And I think I feel quite strongly that in patients who don't have the common mutations, it's worth attempting to get access to some of this fancier genetic sequencing, which is not yet funded in Australia, unfortunately usually costs a lot of money, but can be done through research programs such as ours. So the program we're running, although the testing may cost about $5,000 per patient, the cost to the individual is nothing because it's covered by a research grant. And that's a way of getting access to things that perhaps patients wouldn't be able to get. So thank you very much. Last thing, we make a lot of patient information packs, and we've really tried to consciously make some specific handouts for mucosal melanoma because it's a different disease, which Danielle's led. And because of the commonness of mucosal melanoma in non-Caucasian populations, we're proud to say we have those pamphlets at least in Chinese and Arabic and hopefully other languages soon.
Wow, thank you so much, Matt. That was an incredible summary and really quite complex, and I think really demonstrated some of the challenges that our mucosal melanoma patients have in sort of understanding what the treatment options are and where to get the right help and support. I just want to encourage everyone. I can see we've got some questions heading into the Q&A box, which is wonderful. We are holding those questions to the end when we will bring Matt and our next speaker, Judy Maloney, back for a Q&A session panel together. So if you do have questions that are in your mind, please drop them into the Q&A box now, and we will do our best to get to them at the session at the end. So yeah, thank you so much, Matt, for an incredible presentation. I'd like to introduce our next speaker now, Judy Maloney, who spent most of her life in Victoria, but has moved to the Queensland's sunny coast 25 years ago. And almost immediately she started to suffer from what seemed to be allergies and sinus issues. She was then diagnosed with nasal mucosal melanoma in 2019. And after recurrence in 2020, she was stage 3B, and this qualified her for immunotherapy treatment. She's had 13 infusions of nivolumab and suffered a number of side effects. She currently has no evidence of disease and still undergoes routine PET and CT scans. I'm really delighted that Judy's here to share her story today. And I know that she, along with the team at Melanoma Patients Australia, are very passionate about raising awareness of this very important rare form of melanoma. So welcome, Judy, to the team.
Thanks, Victoria. Hello, everyone. I think my nasal mucosal melanoma story began when I moved to Queensland. And I started to suffer from sinus issues, which continued for a number of years. I saw a number of doctors as I felt there was something wrong. I started to do daily nasal rinses. I had my amalgam fillings and root canals removed. I went on a low-carb eating plan and I started to take vitamin C in water, hoping that would all help. I started having small nosebleeds every day, which continued for a number of years. Until then, I'd never had a nosebleed. I needed to always have a tissue in my hand, as there would always be blood trickling out of my nostrils. I was snuffling and breathing through my mouth. I had a rash on my face, which I was told was rosacea, although I'd always had clear skin and never had acne. My voice changed. My right nostril was smaller than my left. In 2017, I had a major nosebleed. In fact, it was more like a hemorrhage. It was very scary and definitely not normal. My ENT prescribed a corticosteroid to go into my nasal rinses, and that helped. But in 2019, I blew a polyp out of my nose. My doctor was adamant that it was a blood clot, despite my protest, and he threw it in the bin. 2 months later, I could see a large tumour growing down my right nostril. I had surgery to remove it, and the pathology took a while to come back. When it did, I was told that I had mucosal melanoma, which is extremely rare. I was a bit stunned. Not so much that I had cancer, but that it was rare. I'd never heard of mucosal melanoma, and Dr. Google, which was the only place that I could get any information, revealed a very aggressive cancer with a poor prognosis that no one seemed to know anything about. I thought, well, I can't change this, so I accepted it, but I did feel very alone. I had a second surgery and obtained clear margins, which was the best outcome that I could hope for. I had a blood sample sent to Germany to test for circulating tumour cells. This is a test that wasn't available in Australia at that time. The results showed a number of live, potentially malignant tumour cells in the growth phase of the cell cycle. At the time, I didn't really know how to interpret that result. But no one on my medical team seemed to be that interested. I was offered radiation, and after careful consideration, I elected not to have that due to the side effects that I was told I would occur. So at that point, I didn't qualify for any further treatment. So although it's somewhat controversial, I actually had some vitamin C infusions, but basically I had to wait till something else happened. Well, something else did happen 11 months later, when I noticed that one cheek seemed to be a bit puffy, and I found a tumour in my cheek. A fine needle biopsy confirmed that it was mucosal melanoma, despite 11 days earlier having received a clear PET scan. The tumour was a decent size, so it either grew very quickly or the PET scan missed it. So this happened just as COVID hit Australia, and due to the aggressive nature of mucosal melanoma, I was told that there's no time to wait to get an appointment with plastic surgeon. So with my consent, my ENT surgeon removed the tumour in my cheek by going in through my mouth. I just wanted to get it out, knowing how aggressive mucosal melanoma is. So after this recurrence, I was staged at 3B and I qualified for a year of immunotherapy. Unfortunately, I did have a number of side effects. I suffered from peripheral neuropathy in my hands from the first infusion. I also had vitiligo, or loss of pigment, in my skin. My dermatologist was actually delighted at that because she said the immunotherapy is working. I developed pneumonitis and I was coughing up awful chunks of mucus. I broke my rib from coughing. My thyroid failed, but that was expected. After my final immunotherapy infusion, I became very unwell. I had fatigue, cognitive decline, couldn't breathe properly, colitis, vomiting, and my weight had gone down to 44 kilos. I wasn't functioning in life and I was spending most of my time sleeping. Although I was vocal about my symptoms, while sympathetic, no one seemed to be too concerned. It was really difficult to advocate for myself, but I knew that I was sick. I attended my local hospital ED and they admitted that they didn't know much about immunotherapy, so they tried to contact my oncologist practice, but no one answered the call. So I decided I'd get a new oncologist. Luckily, I had an appointment within 2 weeks, and it took only one blood test to reveal that I had secondary adrenal insufficiency because the immunotherapy had attacked my pituitary gland. After a few days in hospital with urgent treatment, I just felt like a new person. So I take hydrocortisone for that 3 times a day, and I need to wear a medical bracelet. I thought, well, at least I don't have skin melanoma. But last year, my dermatologist took a scrape from a very tiny little freckle, and the pathology confirmed that it was level 1 skin melanoma, which was removed immediately. Shortly after that, I had an irregular PET scan, and my oncologist thought mucosal melanoma had spread to my tongue and neck lymph node. Spreading to my tongue or palate is a fear that I have. So this brought a sense of reality of what might come. I tried to remain calm, but it was hard to not have negative thoughts. The next biopsy came back as inflammation, and the tongue biopsy needed to be done under a general anaesthetic. And I was very lucky that it too came back as inflammation. So since then, my scans have been there, showing no evidence of disease. But this is a sneaky cancer and it requires a lifetime of vigilance. When I joined Melanoma Patients Australia, I felt a bit alone, as everyone had skin melanoma. But I was connected to another mucosal melanoma patient who has become a friend and a support person. I'm very grateful that MIA has set up a group, a support group for the few Aussie MM mucosal melanoma patients to come together to support each other, and also to nurse Emma, for spreading her awareness. I'm also a member of an international mucosal melanoma community of approximately 1,100 patients. It's very informative and comforting to talk with others who have the same cancer, even if it originated in a different place. If ever there was a large group of mucosal melanoma patients that could be utilised for research, that group is it. I'm very lucky that I'm doing well. There are mucosal melanoma patients who are not, but there is now hope and survivorship is improving. The key to early diagnosis, I feel, is, and better outcomes, is to spread awareness, in particular among primary care physicians who will probably never have mucosal melanoma cross their paths. So I'd like to thank MIA and NPA for hosting this webinar. Although I'm way out of my comfort zone speaking here tonight, it was an opportunity that I couldn't refuse, as I feel it's important to spread awareness about mucosal melanoma, which occurs in places where the sun doesn't shine. Thank you, everyone.
Thank you, Judy. That was incredible and very brave of you to share what's been a very personal and very challenging journey with mucosal melanoma. But wonderful of you to share it with so many of us on the webinar tonight. I'd like to welcome back our other speaker, Associate Professor Matteo Carlino, and we've got lots of questions coming in through the Q&A panel, which I think is going to keep us busy. So I'd like to open us now to a panel discussion of some of those questions. Now, I did say at the beginning of the session that we weren't able to give personalized, individualized advice, medical advice, and there are a few questions in the Q&A that are kind of heading in that direction. But when I look at those questions, I think Matt, perhaps you can help us to maybe talk through, I think there are some issues around the protocols for treatment. So once you've had surgery or radiation, what qualifies somebody to go, for example, onto a chemotherapy or an immunotherapy treatment? What are the protocols that are in place now? And are they standardized across Australia? Yeah. It's a question that's sort of coming out to me as it's a little unclear.
Yeah, so look, a couple of things. I think it's when we're talking about drug treatment, it's important, and we do this, is to break up people. You know, there's sort of two populations. There's this population of people who've had their melanoma removed, and the treatment is about reducing the risk of it coming back, right? And then the second population is the patients whose melanoma either can't be removed surgically or has spread somewhere else. And so when you're looking at that group where it has spread somewhere else, the standard approach really is those patients need treatment and will have treatment. So the question in someone who's got melanoma that has moved to their lung or their liver or somewhere else is not, do you have no treatment or do you have treatment? I think the question is, what treatment do you have? And so whenever I'm seeing anyone with treatment, I always have, you know, I sort of have standard options and clinical trials. And so my first thing is my standard options for melanoma are one immune drug, nivolumab, pembrolizumab, two immune drugs, the ipi-nivo that people may have heard mentioned, and that third option of clinical trials. And I'm always, whenever I've got a clinical trial open or option for a patient, I'm always asking myself, is the trial option potentially a better option for this person? Or actually, is the trial not a better option for certain reasons? And those reasons may relate to the trial. You know, I don't think this trial is in the best interest of this patient. for very individual reasons, or it may be that something about the patient means that trial's not a good option. The drug has a risk of causing heart side effects, and that person has had a heart attack, 6 months ago. And so that question is what we're doing. And the other thing we do with that question is, I think one thing we do quite well at MIA is we ask that question broadly. So if I saw someone at Westmead tomorrow and I'd say, well, actually, look, the trial open at Westmead is not in your best interest, but Alex, my colleague at MIA, has got a trial that's available for you. I would encourage that person to drive down the freeway. So that is a group of patients where we're deciding what treatment to use. Often the standard therapies, particularly combination immunotherapy, may be the best option. The next group of patients are the ones where we've given a standard treatment and it hasn't worked, or it did work and stopped working. And then we're looking at different questions. The perhaps harder group to make a decision in is the people who've had surgery and there's no melanoma there, but we acknowledge the risk of it coming back is real and potentially high. Because those patients have the choice between having no treatment and having treatment, acknowledging that the treatment has a risk of side effects. And so while some people's natural inclination is to say, well, look, I've had a melanoma, it's been removed, give me drug treatment. If I can't confidently tell you it's going to reduce your risk of recurrence, it's a very personal and tough decision. And though there can't be a one size fits all. So the answer can't be everyone with mucosal melanoma after surgery gets drug, or everyone with mucosal melanoma doesn't get drug. I think it's a pretty complex discussion. For most patients, I have that discussion probably over a couple of visits. It's very rarely I see you today, we decide today. I just want to touch on one question from Roy, which I think is a really good question. And I'm going to be, he commented about the mRNA vaccines. So people may have seen that I and others ran a trial with a drug company called Moderna, where we gave everyone pembrolizumab and some patients got a vaccine that was individually made for them. The vaccine is very similar to the COVID vaccine in design, but instead of being anti-COVID, it's anti-your melanoma. And somewhat disappointingly, and not through a lack of screaming on some of our parts, that trial only allows people with skin melanoma, which I find really a bit disappointing. So I was just in Japan at a meeting with a number of Asian doctors, Asia Pacific doctors, with a couple of large drug companies. And our argument was, don't put mucosal people in that trial. Create a separate trial just for mucosal patients. There's enough of them. If you ran a trial around the world with just mucosal patients, we could put 200-300 patients in 2 or 3 years on that trial and work out, does that vaccine help or not? And if it helps, we'll have a discussion with the government about funding it. But by the same token, if it doesn't help, we shouldn't do it. And so it's disappointing that that type of treatment's not available to mucosal patients. But I think we need a separate trial, not just putting 10 people onto a trial of 1,000 people with skin melanoma, because then I can't tell someone in 5 years' time, does that vaccine help? And that's what people want, drugs that are going to help them, not for the sake of it, in my mind.
Thanks, Matt. And I think that raises a really interesting question about the role of advocacy and how do we advocate for patients with mucosal melanoma better, often because they're a rare and low number of people impacted. Clinical trials aren't ran, treatment options aren't necessarily available. And I know, Judy, you feel very strongly that that we need to raise awareness. We need more work in the early detection space to raise awareness with primary care clinicians, but also with clinicians like Matt described earlier, the ENTs and the gynecologists and specialists in those arenas, as well as clinical trials. Judy, have you got some ideas on what we could be doing better to shout louder and make sure that we get mucosal melanoma on the map?
Well, I've been shouting because I'm writing letters to gynecologists, and my ENT actually when I was diagnosed, he told me that on the Sunshine Coast, they meet monthly and they talk about things. They pick a subject and that's what they talk about. And after he had me come along and had my diagnosis, he said, guess what this month's topic was? So he spread it amongst his ENT colleagues on the Sunshine Coast. But I also know of someone who goes to a fairly well-known gynecologist in Melbourne, and she spoke to her about a friend of hers who has vulval mucosal melanoma, and she'd never heard of it. So I think maybe I tell everybody that I see, I just talk about mucosal melanoma if they're interested, because I just think if somebody knows about it, and that goes for nurses in the hospital, most of them, when I go in for scans or whatever, they haven't heard of it. When I had my immunotherapy, none of them had ever heard of it. So I think talking about it, I've been writing to politicians. This webinar tonight is just wonderful and will probably reach far more than what my letters will. So yeah, I don't know what the answer is, but for sure awareness, because I think GPs, as I said, I doubt the average GP would never have it cross his desk. So my GP didn't have a clue, and despite my protests, because to me the polyp did not look like a blood test, but he just said no, it is, and threw it in the bin, no pathology. Now, had he tested that, I don't know if my outcome would have been any different, because I probably wouldn't have qualified for any treatment at that point. So I think we just need to talk about it.
Talk about it more. And Matt, from your perspective with the clinicians, the medical community, the pharmaceutical companies, is there more we could be doing?
Look, I actually think so. This may be the wrong thing to say, but I think the Australian government's been quite good. All our drugs are approved for melanoma not specified, and one could argue that the data on mucosal melanoma is less, and but the indications for nivolumab, pembrolizumab, ipi/nivo say melanoma. So we can use those drugs. Now, the harder question is, just because you can, just because we can prescribe a drug, this is not just a comment about melanoma, there's more to it than just because you can. So I think the advocacy we actually need is the bigger pharmaceutical companies, because I had that cut and paste from that clinical trial protocol. The ability to say we're going to run a trial in mucosal patients, and we can prove to them we'll get that there will be enough patients, and I would run it, not just in China, because most of those Chinese studies are Chinese drug companies. To the credit of the Chinese, they've done a really good job. But I would have an international study, and you'd be we would get the hundreds of patients we need. And so I actually think the advocacy needs to be with drug companies. There's a number of US support groups who are quite influential with drug companies. And in some ways, the American regulators approving a drug based on a skin trial almost does us a disservice, because the argument is, well, you don't need a mucosal trial, the drug gets approved anyway. But the missing bit then is the data. Getting the drug approved is great, but I want to be able to tell people the drug works, and it's 50% better than the other drug, or it's no better than the other drug, don't have the more toxic treatment. And so it's almost like, because we get the drug approved, we don't get the good clinical trial. There was just a couple of other questions. I think someone asked a question, someone who's currently getting ipi/nivo, about should I be getting a VEGF drug? And I put this in the arguments of, I think ipi/nivo is still the standard of care for many melanoma patients. Maybe not all, But many of these trial options are what you do if ipi-nivo doesn't work. So my hope for that person and lots of people is you don't need a second line clinical trial because your first line works. And certainly for many of my patients I've had discussions with recently even, we make a decision to not go on a trial necessarily and use ipi-nivo, acknowledging that if it doesn't work, we look around for what's best. And that may be one of those targeted therapies that we've talked about accessing, or it may be one of those VEGF drugs, or it may be something else. And so I sort of hope, hope this comes across the right way, that you don't need a clinical trial because the thing you're on at the moment works. We also have clinical trials that are first line, but they're different situations. It's always good. I think the first thing is to say, whatever you're on, no matter what it is, if that works, stick with it. If that stops working, you and your doctor will pause, look around and work out what are your options, what are the best options for you as an individual next. Someone else, sorry, Victoria?
No, yeah, if you want to keep going on, there was a question. Was it the one about one of the
Dacarbazine?
Yes.
Yeah, so dacarbazine, for people who don't know, is an older form of chemotherapy, was the common chemotherapy for melanoma back before immunotherapy existed. I personally think if you're going to give any treatment, I try to give the treatment that has the most evidence. So if I was going to entertain using chemotherapy, I would actually use the chemotherapy that was used in that Chinese trial I spoke about. I would acknowledge that, it's a trial from one hospital with a population that's slightly different to us. But if I think I was going to use chemotherapy rather than use dacarbazine, I would use the drugs used in that trial. Those drugs are so cheap that, they're free. They're drugs that, and so is dacarbazine, to be fair. So I would actually, if I was giving chemotherapy for mucosal melanoma, I would follow the Chinese evidence. Do I know that's better than dacarbazine? No, I don't. Because dacarbazine and the tablet in that chemotherapy are very similar drugs. But the general principle is you look around for where there's the most evidence and you go with that, even if it's not the best evidence. But dacarbazine is very similar to one of those drugs. So it may be someone thinking, making that pretty rational jump.
Thanks so much, Matt. And one of the we did a session last week on clinical trials, but it is a question that we get asked a lot around how do patients get access to the clinical trials that you've talked about today, especially, for example, if they're based in regional, rural areas, maybe not with one of the major treatment centres. What would you say as a recommendation, Matt, to someone who was wanting to find out more about mucosal melanoma specific trials?
Yeah, so I think one thing that we do pretty effectively, and COVID has improved us in this, is actually email and telehealth. So I had a video health consult today with someone. He has skin melanoma, but the principle's the same. He lives in Queensland. He was interested in one of my trials. So his oncologist emailed me. I think it's often good that reach out comes from your oncologist, because some of the nuance of the eligibility of the trial is sort of subtle. As an example, if you had this side effect before, you couldn't go on this trial, but you might be eligible for that trial, or because of the genetics, this is not an option. So that gentleman's oncologist emailed me. That was last week. We set up a video, rather than fly him down to meet me. That seemed a bit inefficient and not good for the planet. We had a video health consult. I've asked him enough questions. He's asked me enough questions. I've now emailed him some information about the trial. He's going to think about it, talk to his family. And then if he's interested in the trial, he'll fly down to Sydney. So I think getting your oncologist to reach out, and we have, just like you guys have patient networks, you may be surprised or not surprised to know that there are sort of oncologist networks, and we discuss side effects, we discuss treatments, and patients do sometimes travel for trials. So recently on one of my my trials not in mucosal melanoma, but in ocular melanoma, another rare form of melanoma. I've got a patient from Canberra, a patient from Brisbane, and a patient from Perth. Now,
really, Matt, you're getting people from all around the country to come into these.
Yeah, now I don't say that lightly. I really don't encourage people to travel. And if the treatment you're getting can be given to you at home, do not travel. But sometimes getting your oncologist to send an email costs no one anything. You know, costs the doctor nothing, costs you nothing. That's the first step. And my advice is don't travel unless the treatment you're getting offered has a substantial potential benefit to you. We don't, with all due respect, we don't want people to travel for a treatment at Westmead that you could get in Brisbane if it's the same treatment, as an example. And
Judy, for you obviously did quite a bit of self-advocacy, changing oncologists, and you're really understanding that you had an issue and you weren't perhaps getting the answers that you wanted. What would be your words of encouragement to others watching the webinar tonight about self-advocacy and pushing to get answers?
Well, I think as a patient, that's what we have to do. I found it a little bit difficult with my first oncologist. I felt like there was a bit of a power imbalance. I liked him very much, but I felt that there was a bit of a power imbalance. And when I spoke to him about, like, for instance, the peripheral neuropathy, which I got straight away, he just said, no, that's not a side effect of the immunotherapy. But I said, it's on the list. And since then, I've found, lots of patients that I have come across have had that. So, yeah, I think if you're not happy, I needed to change oncologists because if I hadn't, my secondary event, they told me I was very, very ill when I got to the second oncologist. So if I hadn't taken that action, I probably wouldn't be here tonight speaking. The only thing I would say also, I found it very difficult to find an oncologist who had ever had anything to do with mucosal melanoma. So it's difficult to know what oncologist to go to. It's like looking up the yellow pages and trying to pick someone, and it's a bit of pot luck. So I guess I'd ask Dr. Matt, how do you go about finding one of those skilled melanoma oncologists that may have had some experience with mucosal melanoma?
Yeah, I think so. Look, I think there's not thousands of us, but I think there are enough. And you almost put, so there is one oncologist I work with who only treats melanoma. I think she's the exception to the rule, but most oncologists, at least at bigger hospitals, treat one or two cancers. So as an example, about 80% of my job's melanoma, and I do treat also some bowel cancer, which is actually quite handy when it comes to rectal and rectal melanoma, because I'm in the same meeting already. Usually it's the person who sees the bulk of the melanoma. So as an example, I have a colleague in Brisbane who is fantastic. Victoria Atkinson would be the person in Brisbane. In Cairns, there is an oncologist who actually trained at the Melanoma Institute who, surprisingly, has a huge amount of melanoma experience, and you'd argue that Cairns is a regional site. And so it's usually, if you look up Can Refer in New South Wales, if you look at the melanoma MDT, the medical oncologist on that list will be the person. So if you looked up, Can Refer and you typed in Westmead, or there'd be my name there, and you'd go, well, even though this is an MDT for skin patients, I see all the melanoma. And if you looked up that for Newcastle, a bit north of Sydney, you'd see the same. So if a hospital has a melanoma MDT, they will have a melanoma medical oncologist. It doesn't need to be someone who just sees melanoma, right? That's not what I mean. but it needs to be someone that has an interest in. And so you know, I don't see patients with breast cancer anymore because we have breast cancer oncologists. And I know very little about lung cancer because it's been at least 15 years since I've seen someone with lung cancer. So I would use that website.
Trying to find someone with a special interest in melanoma wherever you can, even if it's not their main thing, but they've got a special interest somewhere in their portfolio.
Yeah, that's it. I think that's the best term, special and interest in, but it doesn't have to be all they do. Yeah,
great. I'm conscious we're running over time, but we've got two questions left that I really wanted to get to. One in particular around, you know, is there any testing and what, you know, persons worried about their children, their grandchildren? Is there any, I'm guessing, genetic testing that could help?
Yeah, so there are some familial types of melanoma, but they're quite uncommon. Those families often appear, so there are actually ways to look at people's risk of having familial melanoma based on how many people in the family had melanoma. So, and because in Australia, melanoma is common, even if in your family you had melanoma and your father had it, hypothetically, you probably have sporadic melanoma. So your oncologist would be able to take a pretty quick family history, and there are sometimes cancers that go together that people wouldn't think about. So we often ask people, have you had this, 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 and this? And if we get enough of a suspicion that you might be a person with familial melanoma, we send you to one of our genetics people who will talk to you about testing. But first thing is to go through your family history. Mum, dad, siblings and aunts and uncles is usually what we ask for to start. And if there's enough of a story there, for want of a better word, we soon get you to see our friendly geneticist, who's usually in the same building. And the other thing, you know, they're very good at telehealth because, you know, the geneticist at Westmead can see you if you live in Dubbo, as an example.
Great. I'm stretching it now, but super quick answer if possible, Matt. Scans and melanoma. There's a question, why didn't Judy's melanoma get picked up on a PET scan? What scan should people with mucosal melanoma be getting?
So short answer is don't know for an individual. PET scans are very good for melanoma. One issue is, particularly in areas that have had radiotherapy and or surgery, it is sometimes hard to tease out the difference between post-treatment effects and recurrence. And so as an example, bit like, and I use the analogy, and if there are any of my patients who on the line, they probably have heard me say this, we also need to look at the local area. And the best way to look at the local area is a local area expert. So my patients with gynae melanoma see me with scans, but they see our gynecologist for examinations. If you've had a melanoma in your sinus, you see me, but you also see your ENT surgeon who puts a camera up your nose. And that's sometimes that local looking often needs local eyes. And an ENT surgeon is better looking up your nose than me, and a gynecologist is also better examining you than a medical oncologist. So it's always a team. You know, you have your gynecologist and your oncologist, or your ENT surgeon and your oncologist, as an example.
So more than ever with mucosal melanoma, it's a team effort. Really is. You're dependent upon, you know, multidisciplinary group of people that can contribute to making the best possible outcomes for patients. Wonderful. Well, I'm going to wrap up tonight and say a very, very big thank you to our incredible speakers, Judy and Matt, for sharing your incredible knowledge and experiences. This is an area that we've been very worried wasn't in sufficient limelight, and we wanted to really shine a spotlight. We've worked with Melanoma Institute Australia, and as Matt's mentioned, there's some wonderful new printed resources that are available. From Melanoma Patients Australia's perspective, we now have a wonderful support group specifically for melanoma patients. I think we've got 5 or 6 people regularly attending that group, which is facilitated by the Melanoma Patients Australia telehealth nurse, Emma. So if you're interested in that, I would strongly encourage you to get involved, and you can find out more information at melanomapatients.org.au. I would like to Give you a bit of a reminder about the feedback form. We have a survey that will be popping up when the webinar finishes this evening. We'd be super grateful to hear from you. Your feedback helps us to design great webinars in the future. We will be planning to share the webinar recording with everyone that's attended in the coming days, and we are really grateful for Matt and Judy for the time, and everyone who came along this evening to learn more about this very important and rare type of melanoma, mucosal melanoma. So I'd like to thank everyone on behalf of Melanoma Institute Australia and Melanoma Patients Australia for coming along tonight, and if you want further information, please don't hesitate to get in touch with us. Thanks, everybody.